Invasive ventilation is endless. Most commonly, the ventilator associated pneumonia with malnutrition, with patient discomfort, use of sedatives and muscle relaxant. So it is very safe if we can use non-invasive ventilations, and we can prevent invasive ventilation. Yet it is very effective, as we can see. So we should apply this non-invasive ventilation whenever the situation demands. Thank you.
In CPAP, so IPAP and EPAP both are similar.
Both are same.
Then how to calculate the pressure?
Usually we start with small pressure, low pressure setting like 2 cm H2, and we increase. It takes around 4 to 6 cm of H2, and with the patient's comfort level.
No, suppose a patient with LVF, you are applying CPAP, then how do you assess whether it is adequate or not?
The clinical parameters will improve. There will be decrease in the respiratory rate. The oxygenation level will improve. There will be improvement in the EG level. We should apply it whenever there is hypoxemia or there is problem in the EG level. Not in all patients.
Continuous pressure দিলে তো নিঃশ্বাসটা নেবে কি করে? Continuous pressure দিলে নিঃশ্বাসটা নেবে ছাড়বে কি করে?
The funny part is that the patient usually sleep with these CPAP machines.
তো ছাড়বে কি continuous pressure দিলে?
It is a small pressure. And in case of sleep apnea patients, this CPAP pressure usually it acts like a splint. It's not much of the pressure. It is only 4 to 6 cm of it.
This BiPAP machine,
Basically,
basically this BiPAP machine is in the most of the domiciliary home in USA. It has been most of the company was approved, and most of the obese patients are keeping this in home. It is a domiciliary. Even in India now it is a prescription for doctors for domiciliary treatment for the fast sleep apnea, because most of them are not only for himself but his spouse also. Snoring, huge leading to apnea, leading to so much. So one is this, and second is that COPD patient may now even last year one patient came with one prescription. He kindly give a CPAP machine from Central Hospital Garden for domiciliary use. So some center they are even prescribing that you have to use in this.
Now who will decide? Physician or anesthesia?
No, yeah, this one is
It is separate. Now there is a separate branch called the sleep medicine.
yes, basically.
I think the basic idea of this presentation by Department of Anesthesiology was to make you understand that non-invasive ventilation is something which anybody, any medical professional can do, neither an anesthesiologist nor an intensivist. In fact, a critical care nurse can actually apply a non-invasive ventilation. As Dr. Jha has already said that most of the non-invasive ventilation or ventilators are being used at home, because the patients themselves can apply. They adjust the setting according to their comfort level. And regarding the exhalation, as pointed out by Dr. Bera, there are actually exhalation ports in the mask, and be it nasal, be it oral, and those exhalation ports are meant for the exhalation, and the pressure is kept at such level that the exhalation is not hampered, neither the inhalation is hampered. Actually, ventilation or mechanical ventilation has gone through a huge evolution over the last 300 or 400 years. Although the first mechanical ventilation was described way back in 1700, but after that there was a huge gap of about 250 years till the plague epidemic occurred in 1940s, 50s. At that time, actually the main concept of mechanical ventilation came into use when medical students were made to ventilate those plague epidemic patients. And then the idea of positive pressure ventilation came into vogue and came into medical use. But initially it was negative pressure ventilation because those tank ventilators were available at that time, and gradually, because it was seen that negative pressure ventilation was not giving adequate result for the oxygenation, the ventilation part. So positive pressure ventilation came into use and gradually evolved. This non-invasive ventilation is a recent addition to that evolution process, and this has become very popular in most parts of the world. And non-invasive ventilation, because that the main basic idea of our to get it across to you, that the window period when this non-invasive ventilation can be utilized should not be missed. Because if you miss that window, because there is a very narrow therapeutic window where NIV would be helpful. If you miss that particular window, then possibly you are going to land either with intubation and invasive ventilation, or you might lose the patient. So one has to identify that window and act accordingly, judiciously, so that non-invasive ventilation can be of use and invasive ventilation can be avoided. So that idea should be kept in most of the PGTs and the house surgeons' mind, so that they can apply that mind and quickly take the action or ask the senior about the usefulness of non-invasive ventilation during that part. And this should be available not only in ICU or SICU, this should be available in fact in most of the high dependency areas and the wards as well. Because while shifting a patient from a ward to ICU or SICU may take maybe a couple of hours in our setting. So that time if you lose, then possibly the effectiveness will also be lost. Thank you.
So this NIV is usually positive pressure ventilation.
Yes.
But what I am telling, there is one NIV that is called negative pressure ventilation, and what is iron lung?
That is earlier, that's what I said.
No, it is still in vogue.
I know.
No.
Iron lung, sir, in 1876, the first model, the Graham Bell himself has produced this ventilator, and that was a big box-like machine, and it was
We often like box the patient body inside the box and head outside.
That is called iron lung.
Iron lung was
And
the
inside
first
the
one.
box there is a negative pressure. It usually mimics our normal physiological
Normal
respiration.
physiological.
As we increase the chest expansions and creates a negative pressure inside the lung and the
Negative interference pressure and positive.
Negative
That's
interference.
It is a,
But still it is mentioned in book.
it is a basically for academic interest. And one only rule of thumb, I would like to say that Suryo has given so detailed way how to combat hypoxemia and hypercapnia and what is the setting. The rule is IPAP, increasing IPAP will increase the type 2 failure, means hypercapnia overcoming, and increasing the EPAP will overcome hypoxemia, alveolar ventilation. So if we are increasing 15, suppose 12 to 14, always if our target is hypercarbia, then we have to increase the IPAP and increase the EPAP for the type 1 failure. So basically COPD is the boon for this in early phase. And rest in regarding our heart failure, sometime after application, 2 complications we are facing, immediately fall in BP sometime and saturation fall. But don't be afraid for that, because first 30 minutes, 45 minutes is a very crucial phase for this. We have to watch very carefully, look for phase, how the cooperation, because main important for whole report is the cooperation from the patient. And second, Dr. Vera was thinking, one height before starting, you have to give your hand for the port overcome. Sometimes what happens due to secretion, this port get blocked, mucus get blocked. And if we are applying the old medicine for this and then the port is blocked, then immediately it may lead to the even the very damage. So always before starting we have to look on our own hand, port is working well. Otherwise it is a very good. Second, putting up and gastric. Don't feed the patient 2 hours. One pre and post. I mean 30 minutes pre and post. Otherwise, if patient have taken meal and we are applying of the bypass, immediately they will vomit, aspirate. So the basic fundamental rule for general, we have to avoid the 1 to 2 hour meal over time. And always very narrow, fast application, we have to take 1 AVG, and repeated AVG is the ideal parameter for this.
And also regarding the pressure during expiration, in the case of COPD patients, the work of breathing is huge, and in that case this pressure actually helps the patient. And you may have also seen that in case patients not with ventilation, patient tries to first leave ventilation, keep the during the expiration, close the lips, and usually that's why they generate a peak. This is their own generation of positive pressure during expiration.
But I would like to get you across one word of caution, because it will amount to criminal negligence if we cannot do ABG while administering non-invasive ventilation.
Yes, always.
So that one should keep in mind. If you do not have a adequate backup of ABG, because ABG is so vital in these cases, because you do not know what is happening inside that particular patient, and every 2 hourly or 4 hourly you must do an ABG to see what is happening to the patient, whether pH is decreasing, whether PCO2 is increasing, or PO2 is adequately increasing or not. All these parameters you must see serially. Otherwise, it is almost amounting to criminal negligence if you cannot do that. So that word of caution everybody should keep in mind.
But in case of COPD patients, not only in this our setup or ICU setup, even at present it is recommended that long-term oxygen therapy throughout the life for 15 to 16 hours, number one. Associated with that, you should give the NIV, the result is far better. So that's why most probably one prescription has come for NIV, and it is recommended at present 2012 European guideline, they have written like that you should give LTOT plus NIV. So that's why the prescription has come to Dr. Sengupta.
This is the fact now.
That is the fact. That is the latest stage.